Warm good evening to one and all. Now we have come to at another session of Navigate Medico CME, organized by the National Academy of Medical Sciences. And today the session it's on the management in case of ascites as well as AKI in case of liver cirrhosis patients. And to address the gathering, I would like to welcome Dr. Umesh Kabil sir, the Secretary of Finance. To you, sir.
Namaskar, good evening to all of you. Rakhi ji, pranam.
Hello, sir. Good evening.
Nice to see you after a long time.
Yes, sir. Same here.
Okay, on behalf of National Academy of Medical Sciences, I welcome all the participants, all the speakers, and Chief Coordinator Dr. Ajay Duseja sir. We have with us the Dr. Arka. She is an Assistant Professor in Department of Hepatology at PGI, and she will be making a presentation on management of ascites and AKI in cirrhosis. And Dr. Rakhi would be moderating the session, and we'll have a lot of opportunities for question answer sessions. This particular CME is being live telecast on YouTube. And as I get information from Dr. Our IT consultant, Mr. Ravi, there are 250 people who have already joined on YouTube. Also, what we have is we have online on Zoom. And what we are doing is all these lectures, presentations are being included in the e-library of NAMS, so that any postgraduates or M6 student, MD student, DM students, DNB students, they can log on to the NAMS website and learn from the presentations and the discussions. It's an humble attempt by National Academy of Medical Sciences to initiate this. We expect that there are initial teething troubles, but we hope that these presentations of eminent speakers of the country will become a part of our e-library, and they would be seen, enjoyed, and become educative for all the students who would like to learn about the management of ascites and related issues. Thank you very much. With this, I hand over back to Dr. Chippy, who is the Assistant Professor in Transfusion Medicine at All India Institute of Medical Sciences, and she has been helping us as a volunteer conduct of these CME activities. Dr. Chippy, please.
Thank you so much, sir. Now I take this opportunity to welcome Dr. Rakhi Maiwal ma'am. Ma'am is the professor in hepatology as well as the in charge in the ICU, liver ICU in ILBS. And ma'am is also the vice secretary in International Club for Ascites. So we have a good person to chair this session. And now over to you, ma'am. I request you to kindly introduce the speaker of the session as well as give your remarks for the session.
Thank you, Dr. Chippy, and thank you, Umesh Kapil sir, for inviting me and giving me an opportunity to chair this very important session. And it's a pleasure for me to introduce the speaker, who's a young budding hepatologist, Dr. Arka, who's an assistant professor at the Department of Hepatology in PGI Chandigarh. And Dr. Arka has been a very, very active researcher, and particularly his interest is in the field of non-alcoholic fatty liver disease, liver regeneration, and also he does some endoscopy and he's trying to develop endohepatology. And he's also been the nodal officer for the National Viral Hepatitis Control Program and has several publications already at a very young age to his credit. And it's a pleasure for me to invite you, Dr. Arka, and I look forward to hearing from you on a very important and a pertinent topic, which is a difficult topic for us as managing clinicians. And obviously, as a marker of if you can change the outcomes of these patients, you can actually make a difference, and these patients may do well if you manage and diagnose these patients well. So we look forward to hearing your talk.
Thank you, ma'am. Thank you, ma'am, for the kind introduction. I will just share my screen and begin the presentation. Is the screen visible, ma'am?
Yeah, the screen is visible. I hope it's full screen.
Yeah.
Yeah, okay.
So,
your voice is a little, can we make the audio? Yeah.
Okay, so without further ado, I will start today's presentation, which is the management of ascites and AKI and cirrhosis. I realize that the target audience is the MD students and the DND students. So I will not bombard you with a lot of data. Rather, I will try to give you evidence-based concepts and how to do the management on a practical basis. So this will be the outline of my talk. After the introduction, I will briefly go through the pathogenesis, how to evaluate the patients of ascites, management of uncomplicated ascites, refractory ascites, and then we'll go to SDP and spontaneous bacterial peritonitis, and lastly, we'll touch upon acute kidney injury in cirrhosis. So as we know, ascites is the most common of the three major complications of cirrhosis. So if you consider upper GI bleed, hepatic encephalopathy, ascites would be by far the most commonest of the complications of decompensated cirrhosis. And 50% of the patients with compensated cirrhosis go on to develop ascites during 10 years. But the occurrence of ascites is a landmark event. Why? Because it drastically changes the prognosis. So once the patient develops ascites, around 15% will die within 1 year, and almost 50% will die within 5 years. So the pathogenesis of ascites, it entails two theories. The old theories are the underfill theory and the overflow theory. So the overflow theory, this is an old theory which basically suggested that the main reason for the formation of ascites was some unknown anti-natriuretic factor was being produced by the kidneys, which is resulting in too much of retention of fluid. And the underfill theory used to suggest that there is a lot of hepatic lymph production once cirrhosis occurs, and all of this lymph cannot be returned back to the circulation via the lymphatics. Therefore, there is an underfilling of the circulation, which results in activation of sodium and water retention mechanism. But currently, the theory that that seems to be in vogue is the vasodilatation hypothesis. Actually, this is kind of similar to the underfill theory, but over here, the underfilling of the circulation, that is the hypovolemia, is actually occurring due to vasodilatation. So this is a flow chart that shows the pathogenesis of ascites. So the key thing is that once the cirrhosis develops and there is increased hepatic fibrosis going on, there is changes in the nitric oxide. So the intrahepatic nitric oxide goes down, whereas in the splanchnic circulation, the nitric oxide goes up. Similar occurs for other vasodilators. So in the other vasodilator levels in the splanchnic circulation goes up while it goes down in the intrahepatic. And together, so the increased splanchnic nitric oxide levels is the resultant splanchnic vasodilatation. Now, because the increased intrahepatic resistance and the portal hypertension, there will be opening up of the portosystemic collaterals, which will result in increased portal blood flow, even more increased blood flow. That will cause even more shear stress on the endothelial cells, resulting in even more production of nitric oxide and worsening splanchnic vasodilatation. So this splanchnic vasodilatation is the key event. Now, once there is vasodilatation, there's an effective hypovolemia. And because of this effective hypovolemia, there's activation of other vasoconstrictor systems like the renin-angiotensin, the RAS system, activation of the sympathetic nervous system, the vasopressin system, all of which will ultimately result in retention of sodium and water in the kidneys, resulting in the formation of ascites. Now, note, whether it be hepatorenal syndrome, hyponatremia, ascites, spontaneous bacterial peritonitis, these all kind of go hand in hand and is related to the vasodilatation that is occurring in the setting of cirrhosis and portal hypertension, leading on to hypovolemia and the activation of the RAS system and the sympathetic nervous system, which can potentially cause all of these complications. So how do we grade the ascites clinically? So often in the ultrasound, you'll see it's written as grade 1 ascites, grade 2 ascites. So what does that mean? So grade 1 ascites is basically just mild ascites that is only detectable by ultrasound. Grade 2 ascites is a moderate ascites, and that will manifest basically, we can, on examination, we'll detect that on using shifting dullness. Grade 3 ascites is a large or a gross ascites. Remember, if the ascites is very tense, in that case, shifting dullness is often absent. And in these cases, fluid thrill will help to detect the ascites. So how do we evaluate these patients with cirrhosis and ascites? Certain tests are done for the evaluation of the liver disease. We look at the etiologic workup. So does the patient have hepatitis B, hepatitis C? Are there other metabolic comorbidities? Depending upon the age and the clinical scenario, what is the autoimmune workup? What is the ceruloplasmin? Like that. So some tests will be done to look for the etiology of the liver disease. And obviously, we look at a liver function test and other coagulation parameters like a PT-INR, complete blood count, and imaging. Upper GI endoscopy for variceal screening is obviously done in all patients with cirrhosis, and sometimes in selected patients, a liver biopsy may be done, particularly when we are not able to find an etiology, and we feel that finding an etiology may change the management. So this is basically the evaluation of the liver disease per se. What about the evaluation of the renal and circulatory function, which is fundamental to the occurrence of ascites? We need to look at our serum creatinine and electrolytes. This is very important because we'll be giving the patients diuretics, which can result in derangement of these parameters. The measurement of the urinary sodium, preferably a 24-hour collection, urinary protein, and sometimes we also look at the spot urine sodium potassium when the 24-hour collection is not available. But ideally, it should all be 24-hour collections. Look for the urinary sodium. And what is the significance of the urinary sodium? That I will come to a little later. And also we need to look at the arterial blood pressures. What is the mean arterial pressure? Because like I said, the diuretics will all have a role to play. And lastly, obviously the ascitic fluid workup. So ascitic fluid workup, when do we do a diagnostic paracentesis? A diagnostic paracentesis should be done in all patients with a new onset grade 2 or grade 3 ascites. So all patients with new onset clinically detectable ascites should undergo a diagnostic paracentesis to establish why is the ascites occurring. And in other patients, any patient who is hospitalized for worsening of ascites or any complication of cirrhosis or acute kidney injury, suspicion of spontaneous bacterial peritonitis, all of these patients should undergo a diagnostic paracentesis, particularly to rule out spontaneous bacterial peritonitis. The point that I really want to emphasize among all the residents is that paracentesis is an extremely, extremely safe procedure. All our patients with cirrhosis will have derangement of INR. INR derangement does not contraindicate a diagnostic paracentesis. Yes, if there is clinically evident DIC, then we should not go ahead with it. But apart from that, there is no need to correct the platelets or to correct the INR prior to going ahead with the paracentesis. What are the investigations that we send in the ascitic fluid? We'll be sending the total leukocyte count, the differential counts, look at the total protein, glucose, culture, the albumin, and the SAG. The SAG is the serum ascites albumin gradient. And ADA, since India is an endemic country for tuberculosis, ADA should also be done routinely. Now, few points to note. When we are sending the fluid for culture, it should not be sent in a specimen. At least 10 ml of the ascitic fluid should be sent in blood culture bottles prior to antibiotic exposure. Why in blood culture bottles and why so much of ascitic fluid? Because in the setting of spontaneous bacterial peritonitis, the number of organisms per ml of the ascitic fluid is actually very, very minimum. So if you're not sending it in the blood culture bottle, the culture yield would be only around 30%, which goes up to 60% if we are sending it in blood culture bottles. And in selected cases, depending upon the clinical scenario, we may decide on other workup, like at the ADS, yes, we could go for the further tuberculosis workup, malignant cytology, triglycerides, if you're suspecting chylomicrosis, bilirubin if you're suspecting a biliary peritonitis, amylase if you're suspecting a pancreatic cause, like that. If we are sending the fluid for malignant cytology, then 50 ml of fresh ascitic fluid should be sent, and at least 3 samples should be sent from different paracentesis. And lastly, in an asymptomatic patient, he has had prior paracentesis, he has got 10 ascites, and he's basically come for a large volume paracentesis. So whenever we are tapping the fluid, we should send the fluid for investigation. In such a scenario, it is good enough to only send the cell count and the differentials to look for spontaneous bacterial peritonitis. So what is the role of SAG? The serum ascites albumin gradient is fundamental in understanding what type of ascites we are dealing with. There is a common misconception that the SAG tells us whether the fluid is transurative or exudative. No, the SAG has got nothing to do with transurate or exudate. The only thing that the SAG tells us is, does the patient have portal hypertension or not? So if the SAG is high, that is, if the SAG is more than 1.1, it basically indicates that the ascites is a portal hypertensive ascites. The portal hypertension could be due to whatever cause. It could be due to cirrhosis. It could be in the setting of alcoholic hepatitis. It could be due to cardiac ascites, Budd-Chiari syndrome, sinusoidal obstruction syndrome, everything. Whereas if the SAG is low gradient, if the SAG is less than 1.1, it tells us the cause of the ascites is not a portal hypertensive cause. So it can be a malignant ascites, it could be tubercular, it could be pancreatic, it could be anything, but it is not portal hypertension. Note this point, mixed ascites. This is something that we commonly see in India. So what does mixed ascites mean? Mixed ascites means the patient has a portal hypertensive cause of ascites, like he's a cirrhosis. He's got underlying cirrhosis. But then he also develops another cause of ascites, like say he develops tuberculosis. So in this kind of a setting, the patient is cirrhotic and he has got ascites, it will be usually the SAG is still going to be high. So even in the setting of mixed ascites, the SAG will remain high, suggesting a portal hypertensive background. But obviously, the protein will be high in the setting of the tuberculosis. So if we look again at this high gradient thing, one of the things that we know is that what about the ascitic fluid protein? So usually in the setting of cirrhosis and portal hypertension, the SAG is high, but the protein is low. But there are certain situations when the SAG can be high and the protein is also high. Like I said, one of the causes is mixed ascites. But another important cause would be an early Budd-Chiari syndrome. So in an early Budd-Chiari syndrome, the SAG is high because it reflects portal hypertension, but the protein also remains high. So why is it that in early Budd-Chiari, the protein is high? Why is it that in the setting of cirrhosis, the protein is low? So the sinusoids differ from capillaries. The liver sinusoids do not have a basement membrane. Therefore, there is a free exchange with the space of disc. Now, as fibrosis sets in, as the patient becomes cirrhotic, what happens is that these sinusoids get capillarized, that is, they acquire a basement membrane, and this hinders the exchange of protein. Therefore, in the setting of cirrhosis, the ascitic fluid protein content is low. It is less than 2.5, even though the SAG is high. Now, and similarly, but in early BCS, in early Budd-Chiari, when the sinusoids are not yet capillarized, the sinusoids still do not have a basement membrane, there will be free exchange of protein, and hence the protein content in early Budd-Chiari is high. But in late Budd-Chiari, once the sinusoids again gets capillarized, the protein will become low. So this is a schematic diagram showing the workup of ascites to try to towards a differential diagnosis of the cause of ascites. Now, the first thing that we look at is, like I said, the SAG. SAG more than 1.1, it tells that the patient must be having some portal hypertensive component. Then we look at the protein. If the ascitic fluid protein is less than 2.5, then it points towards the cirrhotic ascites or a late Budd-Chiari ascites, like that. And there the counts will be very important to see whether the patient has spontaneous bacterial peritonitis or not. This is something I'll discuss later on. Whereas if the SAG is high, patient has a portal hypertensive cause, but the protein is also high, then the various reasons could be a cardiac ascites or a Budd-Chiari. On the other hand, if the SAG is less than 1.1, that basically rules out a portal hypertensive cause of ascites, and it could be due to a variety of causes, whether it be nephrotic syndrome, malignant ascites, tuberculosis, pancreatic, chylus, etc. And then depending upon that, we will decide as to whether to go ahead with an ascitic ADA if we are suspecting of tubercular peritonitis. If you're suspecting a pancreatic ascites, obviously the amylase levels of more than 1,000 will be indicative of that. And if you're suspecting chylus ascites, and triglycerides will give us a clue.
where do we do the tap of the ascitic tap? Now, so over here, as we can see, so the preferred site of tapping is the left quadrant, somewhere between the left ASIS and the umbilicus. Why do we prefer the left side? Because over in the right side is the cecum. The cecum can get gas filled and can float up, and therefore there is a risk of perforation. Harrison also says that the left side with abdominal skin is actually thinner. I don't know, but that's what Harrison says. And the last very important point is that when we are inserting the needle should be inserted along the Z-track technique. What do I mean by Z-track technique? See, if you insert the needle absolutely straight in, it will form a track between the skin and the peritoneum. And so there will be constant leakage of fluid through that track. So how do we do the Z-track? The trick is you pull the skin downwards and then you enter the needle. So this is the site of entry of the needle. Now, when the skin is released back, this point will move upward. So these, the entry point of the skin and the entry point of the peritoneum no longer lie in a straight line, and therefore there should be less fluid leakage. How do we treat these patients of ascites? The uncomplicated aside, the first line treatment would always be, if the patient is an alcohol consumer, you strongly ask the patient to abstain from alcohol consumption, or if the etiology is some other etiology, like say hepatitis B or hepatitis C, you go ahead and treat the underlying etiology. Sodium restriction is fundamental to the management of ascites. The patient continues to take salt, ascites will never get controlled. Diuretics, we need to discontinue nephrotoxic agents like NSAIDs, other ACE inhibitors, angiotensin receptor blockers, which can hamper the hemodynamics. Those things should be avoided. And lastly, because ascites is associated with an increased mortality, this patient should be evaluated for liver transplant. The second line agents, second line management would include reduction in the dose of the beta blockers. Controversial, I will discuss this in detail. We can consider adding midodrine, particularly in patients in whom the mean arterial pressures are low. Serial large volume paracentesis, again liver transplant, and TIPS, or a transjugular intrahepatic systemic shunt. So the sodium restriction should be moderate. The restriction of sodium is around 80 millimole per day. Very low sodium diet is not advocated, because if the sodium content is very, very low, the diet becomes extremely unpalatable, and the patient is not having adequate intake. It will just worsen sarcopenia, and which will worsen outcomes. So a moderate sodium restriction, it is equivalent to a no added salt diet with avoidance of pre-prepared meals. And we should ask the patient specifically to avoid, achar, papad, sodas, bakery items, etc. What about the diuretics? So which diuretic should we use in the patients with ascites? So these are three very, very important trials. Now, conceptually, if you think about it, furosemide, torsemide, these are loop diuretics, whereas spironolactone, it is an anti-aldosteronic agent. Now, cirrhosis is a hyperaldosteronic state. Therefore, obviously, the diuretic that would work best would be a mineralocorticoid. So it will be an anti-aldosterone agent. What about loop diuretics? Well, loop diuretics alone work. Conceptually, it should not work. Why? Because the loop diuretics act on the loop of Henle. So at the loop of Henle, it is preventing sodium reabsorption. All right. But whatever sodium is there in the filtrate, the moment it reaches the collecting ducts, the distal tubules in the collecting ducts, because of the increased aldosterone levels, that sodium will get reabsorbed. Therefore, loop diuretics alone should not be very helpful. And that is precisely what this landmark trial in 1981 told us, that furosemide is inferior to spironolactone, and furosemide is inferior to a combination of spironolactone and furosemide. So a loop diuretic alone is not very useful. What we need is either spironolactone or a combination of spironolactone with a loop diuretic like furosemide. So then what should we do? Should we give spironolactone alone, or should we give a combination? With respect to this, we have got two studies which have given us contradictory results. So if we look at this study, what this basically told us that the ascitic mobilization and complications are similar, whether we used a combination regime or a spironolactone sequential treatment, starting with spironolactone and then stepping up if required. What it showed us that if we use spironolactone alone as a starting, then it requires less dose adjustments. On the other hand, this 2010 trial, what this showed us by Angeli, what it showed us, the combined regime actually has a quicker resolution of ascites and lower incidence of adverse effects, particularly hypertension. So why the discrepancy in the results between these two studies? The discrepancy is because this study mainly included patients with new onset ascites and preserved renal functions, whereas these patients had more of long-standing ascites, more of recurrent ascites, and a more bad renal functions. So therefore, in patients with the first episode of grade 2 ascites, a sequential schedule can be used. What do I mean with a sequential schedule? That you start off with spironolactone, and if it is not getting controlled on spironolactone, we will be adding on furosemide. However, in patients with long-standing or recurrent ascites, usually we will start off with a combination of spironolactone and furosemide. So this is the way the dose escalation is. So spironolactone, we can go up from 50 mg to 400 mg. So the maximum dose of spironolactone that we can go up to is 400 mg. And for furosemide, it is 160 mg. However, please note that these kind of high doses are never tolerated by our Indian patients. So even though these are the doses that are given in the literature, and these are the doses on the basis of which refractory ascites will be defined, these high doses are not tolerated by our patients. So in general, the practical tip would be, it's a new onset ascites, first time grade 2 ascites, we can start with spironolactone alone, maybe 50 or 100 mg. But if it is a long-standing ascites, then it is better to start off with a combination of spironolactone and furosemide, like a lacilactone or a dietol. So what are the other diuretics that we can use? So instead of furosemide, we can use torsemide. This is also a loop diuretic. Now, the advantage of torsemide is that it has got a higher cumulative 24-hour natriuresis as compared to furosemide. In our institute, we usually use torsemide and not furosemide. Now, the dose equivalency would be 5 mg of torsemide is equivalent to 20 mg of furosemide. What about amiloride? Amiloride is another potassium-sparing diuretic. And this we can use as an alternative to spironolactone in patients who have got tender gynecomastia. Tender gynecomastia is a complication that occurs with spironolactone. In those patients, we can use amiloride. And the dose equivalence would be 10 mg of amiloride is equivalent to 100 mg of spironolactone. For the residents, I think this is very, very important that the ratio of the drugs, spironolactone and furosemide, the ratio of the drugs should be 50. So 50 mg of spironolactone and 20 mg of furosemide, which is basically the tablet that comes as lacilactone. And with, if you're using torsemide, the ratio should be 50:5. So 5 mg of torsemide for every 50 mg of spironolactone. Why is this important? Because lacilactone is always available in this dose ratio itself. But dietol plus is actually available in a number of dose ratios. It's not just available as 55, it is available as 50/10, 25/10, and so on. So basically, the dietol plus has been used a lot in our cardiac patients. And remember, in heart failure patients, the type of diuretic that you want is a loop diuretic because you want to decongest the patient. And the role of spironolactone in heart failure patients would just be to prevent remodeling. Whereas in our cirrhotic ascites patients, like we said, a loop diuretic alone is not going to be much helpful. It is actually the spironolactone which is doing the bulk of the work. And the main role of furosemide would actually be, to balance the spironolactone and prevent the development of adverse effects. So these dose ratios are very, very important. How do we monitor the diuretics? The maximum weight loss that is permitted is 0.5 kg per day in patients without edema and 1 kg per day in patients with edema. Please note, this is the maximum permissible weight loss. If there is over diuresis, then the patient will land up in AKI. The dose escalation should not be done earlier than 72 hours because these drugs like spironolactone, they're basically acting at nuclear level receptors. So it will take some time for the changes to manifest. The dose escalation should take around 3 days, not earlier than 72 hours. And once the ascites is taken control of, once the ascites gets largely resolved, we should reduce the dose of the diuretics to the lowest effective dose. If we do not do this, the patient over diuresis will occur, and again the patient will land up in AKI. In the initial few weeks of treatment, it is very important to frequently monitor, the clinical and the biochemical functions, particularly the serum electrolytes and the renal functions should be closely monitored maybe every week or so. What about urinary sodium? Is urinary sodium needed to be done in all patients with ascites? No. It is primarily done in patients who have inadequate response to diuretics. So how do we interpret the urinary sodium? We'll come to that also. So how do we interpret the urinary sodium? So the 24, if the urinary sodium, 24-hour urinary sodium is more than 78, or if the spot urine sodium potassium ratio is more than 1, what does that indicate? It tells us that the patient is having adequate natriuresis. That is all that it indicates. If the 24-hour urine sodium is more than 78, it tells us that the patient is having adequate natriuresis. Now, if the patient is having adequate natriuresis, that means he should be losing weight. If he is not losing weight, that tells us that the basic reason is dietary incompliance. The patient is taking more salt, and that is the reason why the ascites is not getting controlled. So if the patient is having adequate natriuresis, but still the ascites is not getting controlled, immediately begin to suspect that there is dietary incompliance with sodium and counsel the patient accordingly. Now the question is, how do we know whether the urine collection has been adequate? Is it a true 24-hour urine collection? And for that, we need to look at the urinary creatinine. So adequacy of 24-hour urine collection is indicated by a urinary creatinine of more than 15 in men and more than 10 in females. When do we discontinue the diuretics? We discontinue the diuretics if diuretic-related complications occur, like the serum sodium becomes less than 125, the patient develops an acute kidney injury, hepatic encephalopathy, or incapacitating muscle cramps. If the potassium goes below 3, then obviously we will stop the loop diuretic, we can continue with the antimineralocorticoid, we can continue with spironolactone. If the potassium goes more than 6, then obviously we'll stop the spironolactone. For many of our patients sometimes complain of very severe muscle cramps when we start these diuretics. These are often responsive to albumin infusion, or sometimes we can even start baclofen starting with 10 mg per day, and we can increase it up to 30 mg. What about large volume paracentesis? Serial large volume paracentesis remains one of the mainstays of the treatment of ascites, particularly in refractory ascites, as we will see. So by definition, a large volume paracentesis indicates that more than 5 liters of the ascitic fluid has been removed. Now, it is the first line therapy in grade 3 ascites. It is very important that whenever we are doing large volume paracentesis, it should be accompanied by volume expansion with albumin 6 to 8 grams per liter of ascitic fluid removed. If we are removing lesser amount of ascitic fluid, particularly when we are doing a diagnostic tap, there is absolutely no need for albumin. But sometimes when we are doing what we call a modest volume paracentesis. What is a modest volume paracentesis? A modest volume paracentesis is a paracentesis that is done with a therapeutic intent, but the volume of fluid removed is less than 5 liters. In these patients, particularly if they have acute or chronic liver failure, then we must give volume expansion with albumin. And I will show you the evidence. So why are we giving albumin when we are doing the large volume paracentesis? The reason is because of this. Paracentesis induced circulatory dysfunction, PICD, also called PPCD, post paracentesis circulatory dysfunction. So immediately once the LVP is done, actually there are beneficial hemodynamic changes. Why is that? Because the abdominal pressures go down. So, the hemodynamics improve. However, following this, there is going to be a period of circulatory dysfunction because of intense activation of the renin-angiotensin-aldosterone system due to arterial vasodilation, which probably occurs because of either an increased synthesis of nitric oxide or because of the mechanical changes of the decompression of the abdominal pressures. So how do we define PICD? PICD is defined as the elevation of the plasma renin activity by more than 50% to a level of more than 4 nanogram on day 6 after paracentesis. So please note this, the PICD definition, the plasma renin activity we are checking after day 6. So at the time of doing the LVP or immediately after doing the LVP, it's not as if anything bad is going to happen. That time there's a beneficial hemodynamic changes, but it is only later on when there is an intense activation of the RAS that and the patients can develop AKI, can develop shock. So this occurs in almost 80% of the patients who undergo LVP without a volume expansion. So how can we stop it? Like we discussed, that it is occurring because of activation of RAS and an intense vasodilatation. So either we can do a volume expansion with albumin or dextran, polygylin, etc., or we can take a vasoconstrictive approach to counter the vasodilation. like for instance, for using vasoconstrictive agents like terlipressin, NORAD, or midodrine. So what among these is preferred? Always albumin is the best. So this is a landmark meta-analysis by Bernardi. And what did it show? That when we compare to other volume expanders or when we compare to other vasoconstrictors, albumin remains the best for the prevention of PICD. So if we do not use a volume expansion, 80% patients go on to develop PICD. However, if we do a volume expansion with albumin, then only around 20% will go on to develop PICD. So this is a study from ILBS. So this is a recent study. Basically, what it shows that always our concept was that only when we are removing more than 5 liters of ascitic fluid do we need to give albumin. But this study showed that when we are doing a modest volume paracentesis, which, like I said, is a paracentesis done with a therapeutic intent, but the volume removed is less than 5 liters. In those cases, also PICD is common, occurring in 70% of the patients if they are not given albumin in patients of acute or chronic liver failure. And if we give these patients albumin, then the risk of developing of PICD will be drastically decreased. Therefore, even when we are doing modest volume paracentesis, particularly in patients of acute or chronic liver failure, albumin volume expansion should be done. How frequently will an LVP be required? What is the mathematics? The reason why I'm showing you this is that one of the common things that we observe is patient has undergone LVP today, and 1 week later again he has come up with a tense abdomen and an LVP is getting advised. Does that really occur? So we have removed, on hypothetical scenario, we have removed 10 liters of ascitic fluid in a patient who has a serum sodium of 130, 24-hour urine sodium is 20, and dietary salt intake is 5 grams per day. When do you think we will again require an LVP? First, a few concepts. 5 grams of dietary salt. Dietary salt is sodium chloride. So 5 grams of sodium chloride is equivalent to 2 grams of sodium, and that is equivalent to 88 millimoles of sodium or 88 milliequivalents of sodium. So that is the allowed permitted dietary intake of sodium in our patients with cirrhosis. The non-urinary sodium excretion is 10 millimoles per day. So what is our patient's urinary sodium excretion is 20 millimoles per day. Therefore, what is the amount of sodium that he is retaining per day? He is taking 88 milliequivalents. Non-urinary excretion is 10. Urinary excretion is 20, as has been given in the question. So he is retaining 58 millimoles of sodium per day, this patient. The ascitic fluid concentration is equal to the serum sodium concentration, obviously, because they will balance. Now, when we remove the 10 liters of ascitic fluid, how much of sodium did we remove? So the ascitic fluid sodium concentration is equal to serum sodium concentration. The serum sodium concentration in our patient is 130. Therefore, the ascitic fluid concentration should be 130. Now, when we have removed 10 liters of ascitic fluid, we have essentially removed 130 into 10, that is 1300 millimoles of sodium. Now, our patient is retaining 58 millimoles per day. So in how many days will he end up retaining 1300 millimoles? That would be the time that is taken to reaccumulate 10 liters of ascites, which is coming to around 22 days. If you substitute these figures with the urinary excretion and make it 0 instead of 20, we'll see that the calculations come out to round about 2 weeks. So if a patient is requiring very frequently LVP every 5 days, every 6 days or something, either an adequate LVP is not being done or the patient is continuing to take salt. So now coming to refractory ascites, this is really what is very, very difficult for us hepatologists to control. So how do we define refractory ascites? Refractory ascites is defined as ascites which cannot be mobilized or the early recurrence of which cannot be satisfactorily prevented by medical therapy. Now, this refractory ascites again can be of 2 types. Either it is a diuretic resistant ascites or it could be diuretic intractable. What does resistant mean? Diuretic resistant ascites means is that despite sodium restriction, we have, and despite our escalating the diuretic dose to the maximum dose, that is 160 mg of furosemide, 400 mg of spironolactone, still the patient is having refractory ascites. That is called diuretic resistant ascites. Ascites is persisting despite us having escalated the diuretics to the maximum dose, and the patient remains compliant to salt. What about diuretic intractable ascites? In diuretic intractable ascites, we are not able to increase the diuretic dose to the maximum dose. Why? because prior to that, the patient is developing diuretic-induced complications. The maximum diuretic dose, like I told you, 160 mg of furosemide, 400 mg of spironolactone. That dose is practically never attainable in our patients, in our Indian patients with cirrhosis. So in our Indian settings, we practically never see diuretic resistant ascites. All the refractory ascites that we see in our Indian patients is usually a diuretic intractable ascites. That is, we are not being able to increase the diuretic dose to the maximum dose because of complications of diuretics. Another term which is actually very similar to this term of refractory ascites is a recurrent or a recidivant ascites. A recurrent ascites is defined as ascites which requires LVP at least 3 times in the last 12 months, despite adequate diuretics and despite sodium restriction. So recurrent ascites is possibly precedes refractory ascites. I was talking about the diuretic-induced complications for defining diuretic intractable ascites. So what are those complications? It could be a hepatic encephalopathy. It could be a renal impairment. As of now, for calling diuretic intractable ascites, the renal impairment is designated by a creatinine of doubling of the creatinine to more than 2, or hyponatremia with a sodium of less than 125, hypo or hyperkalemia with a serum potassium being less than 3 or less than 6, or if there is a lot of muscle cramps. So that is basically what becomes a diuretic intractable ascites. Now, for diuretic resistant ascites, where we were increasing the diuretic dose, like I said, that is not something that we see a lot. So what is the duration of therapy that you should give before saying that this is diuretic resistant? Patients must be treated for at least 1 week on salt restricted diet. What do we mean that there is no lack of response or ascites cannot be, early mobilization of ascites cannot be prevented? Lack of response means that the weight loss is less than 0.8 kg over 4 days. That is less than 200 grams of weight loss per day, with the urine sodium output being less than the sodium intake. And what do we mean by early ascites recurrence? The ascites recurs within 4 weeks of the initial mobilization. So I hope this is clear to all the residents. I'll go through this again because it's a little complicated. Refractory ascites is refractory ascites that cannot be mobilized, or the early recurrence, that is within 4 weeks, cannot be prevented. Diuretic resistant, if the patient has refractory ascites, despite us having escalated the dose of diuretics to the maximum dose. This we can practically never do in India. In India, it is all diuretic intractable ascites, where we are not being able to increase the dose because of the occurrence of these complications, either a hepatic encephalopathy or a renal impairment, dyselectrolytemia, muscle cramps, etc. So how do we manage these patients? These patients need urgent evaluation for liver transplant because the median survival is only 6 months. Another point to note over here is that our decisions for listing of transplant, prioritization of liver transplant, are all based on the MELD score, or the MELD sodium scores. Now, in patients with refractory, MELD score includes creatinine, bilirubin, and INR. Patients with refractory ascites may well have normal bilirubins and normal INRs, and their MELD scores may not be very high. That does not mean that they do not need a liver transplant. They should still undergo an urgent evaluation for liver transplant, even if their MELD scores are not very high. And like we said, the first line of therapy would be a repeated large volume paracentesis with albumin support for prevention of PICD. In patients who are not excreting sodium more than 30 millimoles, we should consider stopping the diuretics because it's not going to be much effective. There's a lot of controversy about the use of beta blockers in refractory ascites. Without going into a lot of detail and a lot of the data, the main controversy started with the landmark paper by Thursday, who showed that patients with refractory ascites have poorer outcomes, have got higher mortality if they are on beta blockers. And subsequently, Mendorfer also showed that patients with SBP also have possibly higher mortality with beta blockers. Subsequent to that, we have had several studies, some of which I have listed over here, that no, these patients do not have a poorer outcome with beta blockers. In fact, if we use beta blockers in these patients, the mortality is lower, even in these bad group of acute and chronic liver failure patients. So why, again, this discrepancy in the observations that we have seen? So if you look at these studies, what you will find is that the baseline mean arterial pressure was actually lower in the patients who were on beta blockers. Secondly, the MELD scores were very high. But if we compare it to the studies that have had the positive results, what we will find is that no, the mean arterial pressures are higher and the MELD score, look at this MELD score, it's only 16, 17, 15.5 versus 15. The MELD scores were not very high. So as of now, it seems that beta blockers do not increase the mortality in refractory ascites, although there may be a dose dependent effect. So for instance, this study, what did it basically show? It showed us that if the patient is not taking beta blockers, then the median survival time is only around 20 days, as indicated by this blue line. If the patient is receiving high dose beta blockers, then the survival is even poorer. The survival is only around 8 days. But if the patient is taking low dose beta blockers, the survival is much better, almost 126 days in this study. And the bleeding rates, HRS during follow-up, all were lower in patients who were receiving the low-dose beta blockers. So currently, what does the guidelines say? The guidelines say that refractory ascites and spontaneous bacterial peritonitis are not absolute contraindications for non-selective beta blockers. However, high doses should be avoided. So high doses indicated by 160 mg per day of propranolol or more than 80 mg per day of nadolol. If you look at a variceal bleed literature, what we'll realize is the highest dose of propranolol that we usually give, that has been advocated in cirrhotics, is 320 mg and nadolol is 160 mg. So what the guidelines say is that in these refractory ascites group, the maximum permitted dose is half of those doses. So 160 for propranolol, 80 mg for nadolol. However, let me tell you, in our Indian patients, we are not even able to come close to attaining these doses. So maximum that we are usually able to go up is maybe around 60 mg of propranolol or 80 mg at the most. Never are we able to go up to such high doses. However, we should decrease the dose or more rationally, I think, withhold the beta blockers, particularly when there is evidence of severe circulatory dysfunction, as evidence with the presence of systolic blood pressure of less than 90, hyponatremia with the serum sodium less than 130, or if the acute kidney injury is present. However, once the acute phase is tided over, the renal function, the AKI has been corrected or the sodium has been corrected, then we can once again reintroduce the beta blockers. Carvedilol, however, is not recommended in this setting. For variceal bleed, we know that carvedilol is being used more and more for the secondary prophylaxis part. But in this setting, in these patients with refractory ascites who are hemodynamically very unstable, who have got very low mean arterial pressures, in them carvedilol is not recommended. And why is that? Because even though carvedilol causes a bigger drop in the portal pressures as compared to propranolol, carvedilol also causes a greater decrease in the mean arterial pressure, which is likely to be deleterious in these patients with refractory ascites. What about TIPS? TIPS is a transjugular intrahepatic photosystemic shunt. So in TIPS, basically what we are doing is that we are shunting the portal vein directly to the IVC, the inferior vena cava, and we are bypassing the liver. How will it help in refractory ascites? Because TIPS is essentially decreasing the portal pressure by bypassing the the hepatic resistance liver bed. So that way it is decreasing the portal pressure. So it may have some effect on refractory ascites, on variceal bleed, etc. But what could be the problem with TIPS? All the portal blood flow, not all, but the portal blood flow is getting diverted away directly from liver into the IVC. So ammonia, other mediators will also get directly shunted into the systemic circulation without going through the detoxification of the liver. So there could be a higher chance of etching. And that is precisely what has been borne out by these studies. So if you look at all the studies of TIPS, what we do realize is that TIPS results in a better control of ascites with less recurrence at 3 and 12 months. So TIPS is excellent for the control of ascites. The problem is that there could be a possible higher incidence of hepatic encephalopathy. Nowadays, these are possibly lesser with the use of the covered stents and lesser diameter, but there is a risk of hepatic encephalopathy occurring post-procedure in these patients, which should be very well counseled to the patients and the rest. And lastly, the major question is, does TIPS actually improve survival? If it is not improving survival, what is the purpose of doing it? Now, there is controversy over here in the sense that you can see that the various studies are giving us something different results. But what appears is that that is because of the heterogeneity of the patients who were included in the trial. Like I told you that there is refractory ascites and there's something called recidivant or recurrent ascites. Recurrent ascites is ascites that requires more than 3 LVPs in 12 months. Now, in those studies that have predominantly included patients with refractory ascites, like the early study by Lebrec et al. Or the Guinness et al. Study, the survivals with TIPS have been very poor and it is actually comparable to LVP. However, in those studies where the recidivant ascites has been more, like for instance, with Rossell et al. Over here, you can see the survival with TIPS. The Salermo et al. Study is again pretty high. Therefore, the outcomes may be different whether we are dealing with a recurrent ascites or a refractory ascites. So, like I said, retrospective studies now indicate that covered stents, TIP stents can either be a bare metal stent or it could be covered, a PTFE coating covered. The covered stents have got better results with respect to control of ascites and survival. So, TIPS should be considered in patients with recurrent or refractory ascites or when paracentesis is ineffective, particularly when the patient is not a transplant candidate. A small diameter, is around 8 mm of TIPS stent should be used. Why small diameter? Because the bigger the diameter, the more will be the shunting of the portal blood into the systemic circulation and more will be the chances of the hepatic encephalopathy and so on. Diuretics and salt restriction should be continued after TIPS till the ascites resolves and patient should undergo close follow-up. I think more important than knowing when to do TIPS, it is much more important to know when we should not do TIPS. If the MELD score is very high, if the MELD is more than 15 to 18, in those cases, we should not go ahead with the TIPS. Again, what is the reason? Because the MELD score is very high and you are bypassing, shunting away all the portal blood into the systemic circulation, bypassing the liver. The liver at the end of the day gets less blood supply. So should not be doing it in high MELD scores. If the patient has got a current hepatic encephalopathy, then obviously we should not be go ahead. If the patient has recurrent unprecipitated hepatic encephalopathy or chronic hepatic encephalopathy, that's another contraindication. What do we mean by recurrent HE? Recurrent hepatic encephalopathy refers to the occurrence of 2 or more episodes of hepatic encephalopathy in the last 6 months. But please note that the contraindication is for unprecipitated HE. HE where we haven't been able to find out what was the cause. If the HE has got obvious precipitating factor like constipation, that does not contraindicate the TIPS. The other contraindications are pretty obvious, like the presence of active infection, biliary obstruction, multiple hepatic cysts, moderate pulmonary hypertension. This is a very important contraindication. So before going ahead with TIPS, all patients must undergo a 2D echo and an evaluation of the cardiac functions. Progressive renal failure, severe systolic diastolic function, severe coagulopathy, portal vein thrombosis. Now coming to another drug, midodrine. So midodrine is an alpha-1 agonist. So basically, what is refractory ascites? It is just a very severe form of ascites. What was the pathophysiology of the ascites? Vasodilatation. So we give drugs that cause vasoconstriction. So midodrine is an alpha-1 agonist that will cause vasoconstriction and it can cause hemodynamic improvement, better ascites control, and possibly improvement in the renal functions. So the basic way midodrine is acting is that it is helping to increase the mean arterial pressure such that the patients can tolerate the diuretics better. So midodrine should be considered in refractory ascites with low mean arterial pressure. The usual dose is 5 to 15 mg thrice a day. What about the Vaptans? Vaptans are vasopressin agonists. Again, these will cause vasoconstriction. They can cause vasoconstriction or the antidiuretic effect, and that is why it is being used. So the vasopressin antagonists, we know the vasopressin receptors are, there are 3 types of receptors. The V1A receptors are primarily located in the vascular smooth muscle where they mediate vasoconstriction. The V1B receptor, also known as V3 receptors, this mediates ACTH inhibition in the anterior pituitary. But for our purpose in refractory ascites, the receptor that we are interested in is the V2 receptors. These are present in the vascular basolateral membrane of the collecting tubules, which results in the insertion of the aquaporin channels. What are these aquaporin channels? Vasopressin, like we know, are antidiuretic hormone. It increases the aquaporin expression, and because of the aquaporin expression, the urine gets concentrated because there is it decreases the free water excretion, which results in a dilutional hyponatremia. And if we give Vaptans, if we are able to block off this the aquaporin receptors, then there will be increase in the free water clearance. The urine will be dilute. There will be increased free water clearance, which will result in a raising of serum sodium. Now, in the domain of medicine, now Vaptans are quite commonly used for, I think, all causes of hyponatremia until and unless it's a hypovolumic hyponatremia. So as long as it's a euvolumic hyponatremia or it's a hypervolumic hyponatremia, Vaptans are used in the domain of medicine. What about cirrhosis? So if we look at the US FDA recommendation, first recommendation is to limit the duration to 30 days, but it has removed the indication of use of tolvaptan in patients with cirrhosis. Why was that? Because of the description of liver injury in clinical trials, and the ability to recover from drug-induced liver injury may be impaired. But the point to note is that these trials were primarily conducted in patients with polycystic kidney disease who had polycystic liver disease. This is not the same as the population of patients that we are trying to treat who are having cirrhosis. So if we look at the evidence, if we look at the meta-analysis, what we will find is that 2 trials were terminated. These were the Satavaptan trials that I've already talked to you about. However, if you look at the meta-analysis as a whole, it does not show any increased mortality or increased complications of cirrhosis or increased risk of serious adverse events with the use of Vaptans. So you see, with respect to the serum sodium concentration, it favors Vaptans. So Vaptans were significant rise of serum sodium concentration with respect to placebo, significant better control of ascites, however, with no difference in survival. So basically, what is the problem with the Vaptans? So this is an extrapolation of the SALT trials, the Satavaptan trials, of the SALT trials, where they took out the patients who had underlying cirrhosis and then analyzed the effect of tolvaptan in these patients. And what they found is that tolvaptan causes a significant rise of the serum sodium as compared to placebo. However, once the drug is withdrawn, the serum sodium falls back to baseline levels. So this is the problem, that tolvaptan will help to control your serum sodium levels so long as tolvaptan is getting continued. But once you stop the tolvaptan, the serum sodium level once again tends to fall back. Although tolvaptan doesn't really find a place in the ASLD or the ESL guidelines, I must tell you that it is recommended for refractory ascites in the Japanese guidelines. And the Japanese guidelines actually state that tolvaptan should be considered early for management of cirrhotic ascites patients with poor response to diuretics. And it should be started early before the onset of significant renal dysfunction. This is a new device for refractory ascites. This is the automated low flow ascites pump. This is a battery powered pump that can be implanted subcutaneously into the abdominal wall, and it aspirates the ascitic fluid and then transports it into the urinary bladder, from following which it can be excreted in the urine. So small volumes, it only removes small volumes at a time, maybe only around 5 to 10 ml are pumped out every 5 to 10 minutes into the urinary bladder. So because only such small volumes are getting pumped out in the point of time, it does not result in a PICD-like phenomenon, and therefore albumin administration is not required. And up to 4 liters of ascitic fluid is usually removed by the pump per day, but usually only around 500 to 2.5 liters is the setting that is put in. The contraindications would be a loculated ascites, active infection, or severe abdominal adhesions. And since this will require a surgical procedure for insertion, we should give consideration of the surgical morbidity and mortality in patients with cirrhosis. So what is the evidence of the alpha pump for refractory ascites? There was obviously significant reduction in LVP requirement with alpha pump as compared to standard of care. However, the problem was there are significant adverse events with alpha pump, particularly acute kidney injury. However, many of them are treatable, but the alpha pump is obviously very, very costly and it is not available in India. But so it's think for the future, and we need more evidence, particularly with respect to these adverse events, before it can be used more routinely. This is another very, very hot topic. What about long-term albumin for ascites? I have already told you that albumin needs to be given for the prevention of paracentesis-induced circulatory dysfunction, following large volume paracentesis and following even modest volume paracentesis in patients with ACL. But barring that, what about domiciliary albumin, weekly albumin, giving this to these patients? Remember, albumin is very, very costly. And so these are the 2 important trials, the ANSWER trial and the MARK trial. which tried domiciliary albumin in these kind of patients. And the results were completely opposite. So the ANSWER trial showed that the administration of weekly albumin reduced mortality and complication, whereas the MARC trial showed that the albumin administration had no effect. So again, why the difference in the observations from the two trials? So the ANSWER trial used only albumin, but the dose of albumin was much higher, 40 grams twice a week for 2 weeks, and then 40 grams every week. On the other hand, in the MARC trial, that was albumin along with midodrine, but the dose of albumin that was used was much less, 40 grams every 15 days. In the ANSWER trial, during the maintenance phase, we are giving 40 grams every week, and here we are giving 40 grams every 2 weeks. So it's almost half the dose of albumin. And not surprisingly, therefore, in the ANSWER trial, the serum albumin concentrations actually rose. There was an increase in the serum albumin concentration. Whereas in the MARC trial, with the low dose of albumin that was given, there was no significant change in the serum albumin. Again, the MELD scores were lower in the ANSWER trial, which may account for the better outcomes that we saw there, whereas it was higher in the MARC trial. Most important reason why the MARC trial did not find any difference was that in the MARC trial, most of the patients underwent liver transplant very quickly. So the duration of intervention treatment, if you see in the MARC trial, was only around 2 months. Why? Because majority of the patients underwent transplant. So obviously no survival benefit could be demonstrated. On the other hand, look at this ANSWER trial. Here the duration of the albumin was from 8 to 18 months. So the jury is out on this issue about whether we should use long-term albumin on a domiciliary basis, weekly albumin in our patients with ascites. Even though the evidence is a little flimsy, I think most of us, particularly in difficult to control ascites, in refractory ascites, we do give weekly albumin. Not only it helps keep the creatinine levels stable, helps give us a better control of the ascites, but patient's quality of life improves and a lot of other things. However, we should remember that albumin is very, very costly. So although I am saying that we often use albumin in the difficult patients, this does not mean that I am advocating albumin, domiciliary albumin for routine use in all patients with uncomplicated ascites. That absolutely should not be done because albumin is very costly. Okay, moving on now from refractory ascites to spontaneous bacterial peritonitis. So what is spontaneous bacterial peritonitis? It's a spontaneous infection of the ascitic fluid. Now, for practical purposes, how do we define spontaneous bacterial peritonitis? We say ascitic fluid neutrophil count of more than 250 is spontaneous bacterial peritonitis. That is what we do in clinical practice. But the literature actually, it would divide it into true SBP, CNNA, and MNBA. So what is SBP? SBP, not only the neutrophil count should be more than 250, the ascitic fluid culture should also be positive for a single organism, and we'll treat with antibiotics and alcohol. What about culture negative neutrocytic ascites? So there is neutrocytic ascites. ANC is more than 250, but it is culture negative. Now, for all practical purposes, we treat CNNA just like we treat SBP. That is why in clinical practice, in clinical rounds, usually just the presence of ANC more than 250 is taken as SBP, and both of these are taken, as together. What about MNBA? So MNBA is monomicrobial, non-neutrocytic bacterial ascites. So it is non-neutrocytic, ANC is less than 250. It is monomicrobial, therefore on culture, there is a single organism. Now this monomicrobial non-neutrocytic bacterial ascites, this could be two things. Either it could be just a contamination, or it could be that no, you have just tapped it a little too early, and later on this ANC is going to develop SBP with time. So how do we tackle these patients? If the patient is symptomatic, the patient has got SIRS, systemic inflammatory response syndrome, in those cases, we will treat the patient just like we treat SBP. If the patient is asymptomatic, does not have any SIRS, does not have any other organ failures, in that case, we will repeat the ascitic fluid workup when we get the culture report. See, the culture report will come maybe after 48 hours. At that time, we repeat the ascitic fluid, and on the repeat ascitic fluid, if the culture is positive, or the ANC is still more than 250, in that case, we will treat the patient just like SBP. The important point about SBP is that this is another hard indication for the administration of albumin in our patients with cirrhosis. So again, this is a landmark NEGM trial of 1999. And what they showed that they compared antibiotic, that is cefotaxime, with albumin versus cefotaxime alone. And in the group that received albumin, AKI occurred in only 10% compared to more than 33% of the patients who had received antibiotic alone. Again, in hospital mortality in patients who received albumin was 10% compared to 30% in those who received cefotaxime alone. Therefore, in all patients with spontaneous bacterial peritonitis, along with antibiotics, we must give albumin. But look at the dose again that was used in this trial. 1.5 gram per kg at diagnosis, followed by 1 gram per kg on day 3. These are very, very high doses of albumin, which are again very poorly tolerated by our Indian patients. Therefore, in our patients, we generally use.
It's already 7. You have to cover AKI also.
Right. I'll just skip through quickly.
Yeah, just be a little quick. Yeah. Okay.
So albumin infusion of 20 to 40 grams per day. It's a low dose, but for the duration of treatment, not day 1 and day 3, like it was done in that trial, this is what we usually do. And how do we monitor? How do we know whether the SBP has recovered or not? We, in routine cases, we do not need to do a repeat diagnostic tap. However, if there are persistent symptoms of, or if there is persistent organ dysfunction, then we can repeat the diagnostic tap at 48 hours. And if the ANC does not fall by 25%, that suggests that there is a failure of antibiotic therapy, and therefore we should upgrade the antibiotics. What about prophylaxis? Primary prophylaxis for SBP is given to patients who have got a low ascitic fluid concentration with a child Cook score of more than 9, with hyperbilirubinemia and either impaired renal function or hyponatremia. Secondary prophylaxis, this is more important. Norfloxacin is the first-line prophylactic agent. It's usually a lifelong prophylaxis, evaluation for transplant. And this last point is very important, particularly again for our medicine residents. Restrict PPI to those with clear indications. Proton pump inhibitors increases the risk of SBP by more than 2-fold. Therefore, until and unless there's a firm indication for giving PPI, please do not give PPIs just like we do in all routine medicine patients. Don't do that because it increases the risk of SBP. And at the time when the patient has SBP, it is prudent to decrease the dose of the beta blockers or maybe even temporarily stop the beta blockers, particularly if the patient has AKI or hyponatremia or the MAP is low. What about AKI in cirrhosis? So AKI is very common in cirrhosis and occurs in almost 50% of the patients who are admitted. The spectrum of AKI, it includes either an intrinsic or a functional renal failure, and it's a spectrum. So it could either be a structural intrinsic renal disease like ATN. Post-renal obstruction is very, very rare. What about the functional renal failures? There could be a pre-renal azotemia, which is going to be volume responsive, or there could be HRS AKI, which is a volume non-responsive type of functional AKI. And obviously, there is then the CKD part, which could be an HRS CKD or a chronic kidney disease due to other etiologies. It's important to realize that this is a spectrum. In other words, if a functional renal failure lasts for a sufficiently long time, the ischemia continues for a sufficiently long time, it can progress on to structural AKI. AKI per se increases the risk of developing CKD in the future. So it's a spectrum. Which one is the commonest cause of AKI? Pre-renal. So here by pre-renal, I mean volume responsive pre-renal is by far the commonest cause of AKI in cirrhotic patients, being almost 50%. This is followed by HRS, that's around 28%, and ATN is 17%. Post-renal obstructive cause of AKI is extremely uncommon in cirrhosis. So this is the definition of the AKI. This is now very similar to the akin definition or the KDIGO definitions that we follow in nephrology. The definition is an increase in creat by more than 0.3 in 48 hours, or a percentage increase of the creat by more than 50% above the baseline, which is presumed to occur within the 7 days. What do I mean when I say baseline serum creat? It is a creat that is obtained in the previous 3 months, preferably the value that is the one that is closest to admission. Now, this is the ICA definition of 2017. If you compare it to the akin or the KDIGO definitions, what you will find is the urine output criteria is not maintained over here. This is a little controversial because urine output is often low in our cirrhotic patients. However, in the 2019 suggestion by Paolo Angeli paper, over there it has been suggested that urine output less than 0.5 ml per kg per 6 hours may be included as a criteria. How do we stage the AKI? Again, this is similar to our Ekin and KDCO. So stage 1 would be an increase of serum creatinine between 1.5 to 2 times. And stage 2 is rise in creatinine 2 to 3 times. And stage 3 is rise in creatinine by more than 3 times, or creat more than 4 with an acute increase of more than 0.3, or the requirement of dialysis. And then once we start therapy in these patients, how do we say that the patient is progressing or the AKI is regressing? So what does progression means? It means that progression of AKI to a higher stage. So patient had stage 1 AKI, he is now moved on to stage 2 AKI, or he is moved on to stage 3 AKI, needs dialysis now. What is regression? Regression means regression to a lower stage. And partial response means that there is a regression of the AKI stage. Patient had AKI stage 2 begin with. Now he has got AKI stage 1, but the creatinine is still more than 0.3 above the baseline value. That is partial response. And what is full response? When the creat comes to a value within 0.3 milligram per DL of the baseline value. And CKD, that is defined as a GFR of less than 60 for more than 3 months. Now, there has been a lot of change in terminologies that has been going on recently in this field of AKI in cirrhosis. So previously, or what you might have read as HRS1 during your MBBS days, this is now rechristened as HRS-AKI. And what used to be known as HRS2, that is now rechristened as HRS-NAKI or HRS non-AKI. So what's this HRS-AKI? The difference, I mean, there has not really too much change in what is HRS-AKI and HRS1, except in the definition of the creatinine. So HRS-AKI, we are going to define AKI using the Ekin criteria, that is rise in creatinine by more than 0.3 or more than 50% in a patient with cirrhosis and ascites. The renal dysfunction does not respond to volume expansion with albumin 1 gram per kg per day for 48 hours. And the patient does not have any shock. There is no use of nephrotoxic drugs, and there is no intrinsic renal disease as evidenced by the absence of hematuria and normal ultrasound. So what about HRS-NAKI or HRS non-AKI? This would now include 2 components. One is HRS-CKD, which is very easy. GFR less than 60 for more than 3 months becomes HRS-CKD. And HRS-AKD, which is more difficult. HRS-AKD is duration of illness is less than 3 months, but it is not fitting criteria for AKI. This is a difficult thing to understand, and it is still being defined now in our field. And the point I want to really raise is that HRS-AKD, what we know in the nephrology domain, this is not the same as AKD in nephrology domain. So in nephrology, an acute kidney disease is defined as AKI, which does not improve after 7 days of therapy. HRS-AKD is not the same as AKD in nephrology. So I think this should be very clear now. HRS1, we are now calling HRS-AKI, and HRS2 is now called as HRS-NAKI, which includes HRS-AKD and HRS-CKD. Biomarkers for AKI, I will not cover now because of the limited time, but the point that I want to, information that I really want to pass on to the residents is that creatinine is not a good thing. Creatinine is not a good marker of renal dysfunction in cirrhosis at all. Number one, it is influenced by age, sex, ethnicity. A lot of our cirrhotics have sarcopenia, such low muscle mass. From where will the creatinine get produced? Ascites per se increases the volume of distribution, which can lead to an overestimation of GFR. And there are assay-related problems also where bilirubin albumin can interfere with the estimation of creatinine. So as such, creatinine is not a good biomarker for AKI, and we need better biomarkers to predict the development of AKI, to identify AKI at an early stage such that we can initiate the treatment early, to distinguish it from pre-renal AKI from ATN, and also to predict the severity of AKI and who are going to respond to treatment. The details of all these biomarkers I will not be covering. So a patient comes to you with AKI. How do you approach the patient clinically, and how do you approach your differential diagnosis? So in the history, it is very important to inquire about, is there some volume loss that has occurred, which can suggest a pre-renal AKI? Has there been the use of nephrotoxic drugs like NSAIDs, etc.? Then we need to rule out an intrinsic renal disease. See, differentiating a pre-renal volume responsive AKI from HRS or ATN is very easy. If the creatinine improves with the administration of albumin, it is a volume responsive prerenal AKI. If it doesn't improve, then it could either be HRS or it could be intrinsic renal disease. It could be an ATN. So in that case, we need to see, does the patient have intrinsic renal disease? What's going to help us? An ultrasound. Is there any loss of CMD? Is the shrunken kidneys, etc.? The urine analysis, are there casts or RBCs presence, and the 24-hour urine collection of proteinuria. If the proteinuria is present, all of these go in favor of intrinsic renal disease. Another test is a very, very simple test, is a fractional excretion of sodium. This is now come into vogue. It's an age-old test that now seems to be pretty good at differentiating functional, HRS from ATN. In the nephrology domain, prerenal AKI and intrinsic AKI, the cutoff for differentiating that of FANA is 1. So an FANA of more than 1 suggests an intrinsic AKI in the nephrology domain. In our cirrhotic patients, because the sodium excretion is already hampered, these cutoffs are much lower. So an FANA of less than 0.2 suggests functional AKI, while an FANA of less than 0.1 is very, very highly suggestive of functional AKI. And so I think this is an easily available test that we can do to help us differentiate from these things. Now, if the patient does not have intrinsic renal disease, then obviously we will get, like I said, we can give albumin, and if it responds, it's a prerenal AKI. If it doesn't, it's an HRS. So when the patient comes to us, we first see what is the stage of the AKI. What do I mean by stage 1A? Stage 1A means stage 1 AKI, but the creatinine is less than 1.5. Why was this differentiation important? Because previously we used to define AKI in cirrhosis as creatinine of more than 1.5. Now we have changed it. But the issue is that we are going to treat AKI with albumin, which again is costly. So does all patients who have an AKI, maybe with a creat of 1.1, are we justified in expanding the volume with such a costly treatment? If the patient has AKI stage 1A, that is the creatinine is less than 1, then we remove nephrotoxic drugs, we stop our vasodilators, other precipitating, we stop our diuretics, etc., and we follow them up. If it resolves, it's excellent. But if it progresses, the creatinine goes more than 1.5. In that case, we'll start our volume expansion with albumin, 1 gram per kg for 2 days, and see is there a response. If there is a response, then obviously it was prerenal AKI, again, very good. If there is no response, then we see, does it meet the criteria of HRS? Is there intrinsic renal disease? Is there proteinuria? Is there hematuria? Is there RBC cast? Is the ultrasound normal? If it meets the criteria for HRS, then we will go ahead with vasoconstrictors and albumin. And if it is not HRS, then we will think of other specific treatment for definite phenotypes. So what are the vasoconstrictors that we have? We have got terlipressin, we have got norepinephrine, we have got a combination of midodrine and octreotide. We'll not discuss too much about the doses, etc. over here or the studies because of the shortage of time. But the point really is that terlipressin is the one that was first studied and is most commonly used in India. Norepinephrine seems non-inferior or equivalent to terlipressin, usually given in the ICU setting, and is much cheaper than terlipressin and can be used accordingly. The combination of midodrine and octreotide, this is superior to placebo. This is superior to nothing. Standard medical therapy also says superior to placebo, all right, but it is definitely inferior to terlipressin and norepinephrine. So basically, we should be giving midodrine and octreotide only in those patients who are not candidates for terlipressin, who are for contraindications for terlipressin and norepinephrine. So whenever we are giving this, how will we monitor? We will have to monitor the urine creatinine. Like I said, urine creatinine decrease less than 40 by 25%, less than 40 at 48 hours would tell you that the patient is not responding. But apart from the serum creatinine, we also need to monitor the urine output and the mean arterial pressures, because all of this will cause vasoconstrictions, which will cause a rise in the mean arterial pressure. That is the way we monitor these drugs. How long do we treat these patients? The maximum duration of therapy is for 14 days or till a complete response is attained. The doses of terlipressin I will discuss in detail in the next slide. But over here in norepinephrine, I want to draw your attention to the dose of norepinephrine. The dose is 0.5 to 3 mg per hour, which is much different from the norepinephrine doses that we use in patients with shock, which is a much higher dose. So terlipressin, when we use terlipressin for varicose bleed, we give it as boluses, bolus doses every 4 hourly or 6 hourly. But now there is a trend towards using the infusion regime. So this is a study that compared the infusion regime of 2 mg over 24 hours with a bolus regime of 0.5 mg every 4 hours. And what it basically found is that if we use this infusion regime, then there is no difference in outcome of the HRS. So HRS reversal is similar whether we use infusion regime or the bolus regime. However, if we use the infusion regime, the total amount of terlipressin required is going to be much less. And because the total terlipressin required is getting less, the rate of adverse events will be much less with the infusion regime as compared to the bolus regime. Therefore, nowadays for the management of HRS AKI, it is this infusion regime that is 2 mg over 24 hours, escalated step by step to a maximum of 12 mg if there is no drop in serum creatinine by more than 25% at 48 hours. So this infusion regime is now being preferred. Now, whenever we are giving the infusion regime, it is important to remember that the terlipressin should be dissolved in 5% dextrose and not in saline, because this will help to maintain the pH and ensure the stability of the terlipressin. So this is the confirmed trial. This is a 2021 NEJM trial that compared terlipressin with placebo. The importance of this trial was that so long in India we are using terlipressin. In Europe, the whole world is using terlipressin except the US, because terlipressin was not approved by the FDA for use in HRS. So following this trial, which showed that terlipressin was significantly better than placebo in attaining a reversal of HRS, terlipressin has now been approved by the FDA. However, a note of caution. Please look at the very high rate of adverse events with terlipressin. There's a lot of adverse events that can occur with terlipressin because of its vasoconstrictive effect. So it include cardiac arrhythmias, it can include a fluid overload, pulmonary edema because of the vasoconstriction, intestinal ischemia resulting in diarrhea, GI hemorrhage, skin discoloration, etc. So we have to be very, very careful about the adverse effects of terlipressin. Therefore, a baseline ECG is required. We should closely monitor for cardiovascular and ischemic adverse effects. We should monitor these patients for the prevention of fluid overload. If a patient who has responded develops HRS once again, we can repeat the therapy of the vasoconstrictors along with albumin. There is a chance the patient may re-respond. The commonest precipitant of hepatorenal syndrome is sepsis. Therefore, pending culture reports, we should initiate empirical antibiotics in all patients with AKI. TIPS is not recommended in HRS AKI because there is insufficient data. But at the end of the day, remember that all of these patients are definitely going to remain liver transplant, which remains the best treatment because survival is not really improved by the usage of these vasoconstrictors. Renal replacement therapy can be initiated based on the individual severity of these patients. So with that, I will end my presentation with a take-home message that SAG, or the serum ascites albumin gradient, is the most important for pinpointing total hypertension as a cause of ascites. If you have low SAG, that's it, total hypertension is out. Never forget Budd-Chiari syndrome as a cause of total hypertensive ascites. And Budd-Chiari syndrome may be high protein or it may be low protein. It will be high protein in early Budd-Chiari syndrome, or it will be low protein in late Budd-Chiari syndrome. What happens is that when we get a total hypertensive ascites, it's high SAG, somehow in our mind, the only thing that sticks is this is cirrhosis, this is cirrhosis, this is cirrhosis. We should not forget Budd-Chiari syndrome because it is a condition in which a timely intervention is very, very gratifying both for the patient as well as for the physician. Salt restriction is the key for controlling total hypertensive ascites. The patients continue to consume salt, continue to consume sodium, ascites will never be controlled. The diuretic dose ratios are important. Remember, a 50-20 ratio for spironolactone furosemide or a 55 ratio for spironolactone and torsemide. Albumin, the hard indications for giving albumin is in patients with SBP and for prevention of paracentesis-induced circulatory dysfunction following LVP or a modest volume paracentesis. Domiciliary albumin, weekly albumin in other patients with ascites, that's a little more complicated, not yet to be done routinely, but should be done by the specialist, should be considered by the specialists. Refractory ascites has got very poor prognosis, and all of these patients should be counseled for liver transplant. Acute kidney injury, it is very important to differentiate a volume responsive pre-renal from HRS from ATN because the management is going to differ drastically. Sometimes what I find in our emergencies is the medicine resident starts terlipressin from GA0. The moment the patient comes to the emergency, has AKI, they start off terlipressin. Remember, if the patient is truly having a volume responsive pre-renal AKI, and if you give the patient vasoconstrictors, you're going to do more harm to the patient. So the vasoconstrictor should be initiated only once we are sure the patient has been volume resuscitated. And ultimately, vasoconstrictors and albumin remain the mainstay for management of HRS. Terlipressin preferable to give it as a continuous infusion. And again, these patients have to be counseled for liver transplantation. So thank you all. I will stop sharing my slides, and I think we can now take the discussion forward.
Yeah, thank you, Dr. Arka. That was really a very comprehensive presentation. And I'm not sure what will be the format. Can I just ask, do we have some audience questions, or we have to lead the discussion? Sir, do we have some questions from the audience, or? Okay, so while we hear from Dr. Umesh, I would like to ask you, what is your comment on when do we require for all patients? Are you suggesting not to check the coagulation, or for the audience, which set of patients we should be checking the coagulation status before doing the ascitic tab? What is the incidence of hemoperitoneum, and also the use of ultrasound to do the ascitic tab? Where do you place all these modalities and the newer test, the global coagulation test? Because this paper was also presented last year in ASLD about using the point of care test to decide the need of transfusion. So I would like to hear from you your comments on this. Dr. Arka?
Yeah. So as far we will go ahead with the PTR and the coagulation testing model, which we have it, but we should not put a lot of importance. INR would be more reflective of the liver disease severity. INR would be more reflective of the liver dysfunction per se, rather than a coagulation. So, and the incidence of hemoperitoneum following a diagnostic tab is extremely rare. And if it occurs, it's more because we have hit a blood test. We have hit a collateral when we are doing the tab, rather than we do coagulopathic therapy. Again, using a ROTEM or using a sonoclot would result in much less transfusion requirement. But I think before an ascitic tab, going ahead with a ROTEM is a little bit of overkill, because the coagulopathy related bleeding is so up. For more invasive procedures, obviously, I prefer a ROTEM or a sonoclot any day as compared to just an INR or an APTT to decide the coagulation. As far as the ultrasound guidance is concerned, I think until and unless it's an absolute tense ascites, first and foremost, if the ultrasound is available, in all patients, we should do the ascitic tab ultrasound guidance. And the reason I am saying this is because whenever we see the hemoperitoneum, it is because we have hit a blood vessel. That we're not going to do really with the ultrasound. If it's a tense ascites, okay, or if the ultrasound facilities are not available, then no doubt all residents should have the clinical skill to do a therapeutic tab or a diagnostic paracentesis without using ultrasound. But I think nowadays, wherever it is available, it should be used.
Okay. Yeah, I totally agree with you. But what I was talking about was in the context of ACLF patients, uremic, on dialysis, sepsis. That set of patients, I think so. Not for all patients, we don't require point of care tests. But there, obviously, the coagulation assessment, sometimes their fibrinolysis is there. So there, it's very important that we at least look at the coagulation before we put in a needle. So that's it I was talking about. The second part was about the concept of modest volume paracentesis, because we're not replacing too much of albumin. The dose which is recommended is 8 grams per liter, and we're not doing that much of replacement. And that's why most of the times we see complications if we tap these patients more. But I would like to know, in which set of patients would you prefer a modest volume, or for all patients you would go for a large volume and drain the peritoneal cavity? Or how do you do that at PGI?
In general, obviously, I mean, what we have been taught is that you do a large volume paracentesis, try to make the patient as much of ascites free as possible. But I do not believe that should be done routinely in all patients, particularly in patients who are, hemodynamically fragile, a patient with AKI, a patient with shock, patients in bad ACLF. In these patients, draining a lot of the ascitic fluid will just lead to too much of unpredictable hemodynamic perturbations and will result in a downward. In these patients, we always prefer doing a modest volume paracentesis. And like I said during the talk, a modest volume paracentesis is nothing but a paracentesis done with a therapeutic intent, but
but it is just the volume that we are removing is less than 5 liters. So we are doing in the ICU, for instance, the patient has got 10 ascites, having respiratory distress because of that. Do we really need to remove 10 liters to relieve the respiratory distress? We don't. So maybe just removing 3-4 liters or 2-3 liters would be more than sufficient to relieve the respiratory distress. That is modest volume, and I think that is a better thing to do in these kind of patients. And like I said, if they have ACLF, we should replace the albumin. We should volume expand even for modest volume paracentesis with albumin to prevent PH.
Agreed completely with you. And the other thing was about the ascites in ACLF. Like we know that in AKI, we see the ACLF patients, they have different phenotypes and the way they behave in AKI. What about ascites? Would you suggest a different protocol for managing ascites in patients with ACLF? Because there is no study on this, obviously. We don't just want to hear from you your thoughts. How often do you see diuretic-induced complications? And these patients, when they develop this grade 3 ascites, it is very difficult to treat. Sometimes we have to tap twice a day in the ICU setting, ACLF patients. So very, very rapid onset, very rapidly refilling, and very poor tolerance to diuretics. Very rapidly they get into AKI with diuretics. So your observation and your comments on this.
Yeah, it would be very difficult to manage, and in fact, many of them, particularly the canonic stuff, most of them would be having AKI. That would contraindicate our diuretics in the first place. Many of them would be having shock. That would again contraindicate the diuretics in the first place. So I think in these kind of patients, there's a lot of what we are using is a lot of paracentesis along with albumin. If diuretic is tolerable, then and then only. But we are not using beta blockers so much. I know that there is even in ACL, beta blockers can improve outcomes. There's the LBS data also, but we somehow find that not many patients are fit to get the beta blockers with that kind of a thing. Totally. But it's a very, very difficult thing, and ultimately, without a transplant, not much.
Yes. And I have at least very good experience of using tolvaptan for patients who have difficult to treat, but not very advanced, like not child, jaundiced patients and that set of patients who also have liver failure. So if the MEL scores are low and the patient has, so we see like, I think Dr. Virendra Singh has also published, but only in conjunction with the diuretics. It works quite well in mobilizing the fluid. Only thing is the fluid should never be restricted. I see many of my patients coming to the OPD, they go on to fluid restriction, 1 to 1.5 liters, and then they get this AKI and all the other AKD phenotypes which you get in refractory ascites. So that is another message over here for all the young residents who've joined, and please don't restrict fluid. That's not the right strategy. Restriction of salt and monitoring the salt is important, but fluid restriction should not be pursued, because then it adds to all the complications which are there of paracentesis, diuretics, they get leg cramps and all other problems. So that is one.
So many of our patients have this. I see not just our patients, some of our young medicine residents also.
Yeah, I see very often.
So
so everybody is on volume restriction, and the patients themselves are so they feel that the water in which they have in the abdomen is due to if they drink water, so that psych is already there, and if the doctor tells the patient, then it is like established concept that you don't need to take water, otherwise you'll get problems. So that's one thing. Yes.
Doesn't drink will just worsen the complications. So we're actually harming the patient.
You're harming the patient, and that's how they develop more complications, and they get into PICD and all the other, and kidney, obviously, many a times we see. And you were talking very rightly about creatinine not being able to guide us. What is the exact renal function? So my own practice is to do cystatin C in all these patients with refractory ascites, because most of them, they are sarcopenic and creatinine elevation. So one marker which I use is urea. You see very often their urea will be elevated. But cystatin C, there is so much discrepancy. If the creatinine is normal, you may see cystatin close to 1.8 or 2. So it helps you in cutting down on the diuretics, giving more albumin. And it's a very useful test. One-time assessment can give a lot of information where you're suspecting renal dysfunction.
So I think among these biomarkers, I believe cystatin C is already approved for clinical use in the US and Europe. Obviously, it's not routinely available in India, but I think at least for the estimation, particularly for the estimation of the GFR and really deciding is this patient going into AKI, timely stopping of the diuretics would be very helpful. So I think cystatin C has to come. But the other biomarkers, when it comes to differentiating between is it HRS or ATN,
Yeah, that's a separate.
still have a long way to go. Still
Yeah.
many of these things can be brought.
There's a statin C, obviously, it's a marker of glomerular function. There you need tubular markers. But that's another one area where you require some parameter, because sometimes your spot sodiums and all these are not very reliable. But my own experience in the ICU setting is whenever we think of HRS and we see that most of the times these patients have low urinary sodium. We don't see high urinary until and unless they've come on a lot of diuretic induced AKI. If they are having HRS, most of the times your urine spot sodium is also low. So that, but there will be proteinuria, there will be some sediments also. So there will be a very mixed picture. So it gets difficult, and therefore these biomarkers help us in making a lot of management decisions.
And now I think we have got the concept that this is HRS, this is ATN. These are not hard and fast differentiations. These are not absolute different. It's a spectrum. If an HRS lasts for a long enough time, it can progress onto ATN. We know that HRS in ACLF has got a lot of structural problems. It's not just a purely functional disorder. So definitely we need better biomarkers.
And we'll be coming out very soon with the new definitions of HRS, AKD, and all these. And what we see most commonly in the OPD is not AKI. Actually, what we are seeing is AKD, because we do not know the duration of injury has happened within the last 7 days. We don't have. So the revised definitions should come very soon. And it's a very good definition that now we'll be proposing for HRS. And let's see. Okay. So any more questions or anything from the or we can end the session over here. Sir, Umesh sir, Dr. Chippy.
Yes, ma'am, there is no more question in the chat, but the session was very beautifully discussed between ma'am as well as sir.
No, it was fun to interact with him. Yeah. Okay.
Ma'am, now I take this opportunity to invite Dr. A.K. sir to deliver the word of thanks.
Thank you so much. On behalf of the National Academy of Medical Sciences, it is my privilege to thank the speaker as well as the chairperson for this evening for making this session so interactive. For making this session so interactive and useful for the students. I would like to thank the speaker for this evening, Dr. Akhtar De, for making this complex issue so simple for our resident. And I'm sure that the resident have gained a lot of information and practical tips for management as well as for the examination. I will also like to thank the chairperson for this evening, Dr. Rakhi Maiwal, for steering and chairing the session and generating a lot of discussion, questions. I hope this discussion will be useful for the students as well. I will also like to place on record the support which we have been getting from the chief coordinator for this series of session, Professor Ajay D'Souza, who has identified the best speaker as well as the topics. And I am really grateful to him and his entire team for organizing this series of lectures. So I will also like to inform all the participants who are present in this session that in this month, we have 2 parallel series going on. Like on Tuesday, we are covering the management of hepatic problem, and Thursday, we are covering the effective management of common psychiatric problem. So please remember that on Thursdays, we have psychiatry session, and on Tuesdays, we have disorders of liver, which are being discussed by the experts. So I would like to remind again that the day after tomorrow, we are going to discuss another very interesting topic in psychiatry. The topic is autism. And again, eminent expert will be dealing with this issue. So I will request all the participants as well as the PG student to encourage their fellow friends to attend this session. And the last session of the series on hepatic disorder is on 30th of May, where we are going to discuss autoimmune disorders related to liver. So this is what we have planned for the month of May. So with these words, I will like to thank the participant and the PG student who have attended this program. Once again, I would like to remind you that this is the best opportunity for you to interact with the best speakers and best expert in the country. So please send us your question in advance, and we will like to put this question to the speaker so that they are covered during the session. I will also like to thank the Dr. Chippy, who has been helping us in organizing this session and also moderating the session. So thank you so much for your valuable support, and we look forward for your support in future also. In the end, I would like to thank our IT expert, Mr. Ravi, and the entire team who have been working in the background. So with these words, once again, I thank you all for attending this session, and we look forward for your presence in the next session, which is on Thursday. Thank you very much.
Thank you.
Thank you, everyone. I declare the session is closed.